Thanks so much, and thanks to the moderators and sages for the opportunity to speak to you today. These are my disclosures, none of which are related to this talk. So I'm going to talk a bit about the importance of preoperative evaluation for reflux and hiatal hernia in patients who are being considered for bariatric surgery. Talk about the different methods of diagnostic testing for reflux and hiatal hernia, and kind of try to summarize and give a couple possible potential strategies and algorithms for evaluating these patients. So why does this matter? Why do we care if the patient has reflux or hiatal hernia? Well, number one, these are extremely common. Up to 30% of Americans have some degree of reflux, and obesity, as you all know, is a risk factor for GERD. Obese patients are twice as likely as normal weight patients to have reflux. And hiatal hernia is extremely common in patients undergoing bariatric surgery. I'll talk about this a little bit coming up, but up to 50% of patients have a concurrent hiatal hernia. And not only is it common, but it affects the way we manage patients. Number one, reflux needs to be a consideration in the choice of bariatric operation. The two most common bariatric surgeries, gastric bypass and sleeve gastrectomy, are markedly different in their effect on reflux. Gastric bypass offers excellent GERD control, normalizing esophageal acid exposure in up to 90% of patients, where sleeve actually may generate reflux. This is a meta-analysis looking at studies that did pH testing before and after sleeve, and in more than half of those studies, the pH exposure was increased after sleeve. And there was a kind of frightening meta-analysis that was recently published that showed that 11% of sleeve patients have Barrett's detected on surveillance endoscopy postoperatively. So something to consider. And then you have to decide whether to perform a concurrent hiatal hernia repair. We think, all think that performing a hiatal hernia repair is an essential part of any anti-reflux operation, but there's probably no benefit of routine cruroplasty in the absence of hiatal hernia. And opening the hiatus, mobilizing the esophagus does add morbidity. We've had a couple of patients in the last few years who re-herniated immediately after their sleeve, and we had to take them back to the operating room. So how do you evaluate first for reflux in these patients? Obviously, the first step is history. You want to focus on typical symptoms of reflux, heartburn, and regurgitation. And very critical is whether the patient is PPI responsive. That's a very much more specific predictor of whether they do have true GERD. Evaluation of symptoms is fairly good test for reflux. In one study of pre-op bariatric patients, it was 75% sensitive, so detected most patients, but unfortunately not that specific. What about patients with no symptoms? In bariatric patients specifically, 18% will have a positive pH study, so there is a degree of silent reflux in these patients. How about esophagram? Well, multiple studies have showed that there's very poor correlation between esophagram, reflux seen on esophagram, and pH monitoring. So, when I get a report of an esophagram upper GI that said severe reflux to the thoracic inlet, I just X that out and discount it completely because there's no correlation between that and pH monitoring. How about endoscopy? The most powerful part of endoscopy is it allows for also screening of Barrett's, stricture, esophagitis, and then obviously other unrelated pathology, eosinophilic esophagitis, gastric intestinal metaplasia, things that you have no idea the patient had and may affect their management preoperatively. The cons is that, unfortunately, especially if the patient is on PPI, there's low sensitivity, meaning that you don't know that the patient has reflux from the endoscopy. Only 30% will have esophagitis, and you need LAC or D esophagitis to really prove that the patient has reflux, and that's uncommon. And then pH monitoring study is really the gold standard. It's the only test that allows for an accurate, objective assessment of the amount of gastroesophageal reflux. But obviously, this is added cost and either requires an endoscopy to do a Bravo test or a manometry, which patients hate, to do a 24-hour transnasal. So moving on to hiatal hernia, I think this is really interesting. You know, hiatal hernia, whether or not there is one, especially in the operating room, it's really in the eye of the beholder. I just pulled a couple of images from cases I've done in the last couple months, and, you know, I bet if you polled everyone in here on each image, there would be a wide variation in whether people thought there was a hiatal hernia or not. And that's been borne out in the literature. When you look at single series, whether, you know, or not the surgeon fixed a hiatal hernia based on intraoperative assessment, there's ranges in the literature 7% to 49%. And these are the same types of patients. There's no real difference in demographics. So obviously it's just the surgeon's judgment is incredibly different as to the presence of a hiatal hernia. That's borne out in the MBS-AQUIP database. Hiatal hernia repairs occur in 21% of sleeves and 11% of gastric bypasses, even though the patients who are having sleeves have less reflux. So you would think they have less hiatal hernias. So obviously the surgeon assessment is coming into play here. Just in our own hospital system, there's 4 hospitals that do bariatric surgery. Huge range of concurrent hiatal hernia repair rates from 6% to 39%. You can guess which our academic place is. So, you know, when you sum this up, surgeon intraoperative evaluation of whether there's a hiatal hernia is not an accurate method of assessing this because of the degree of variability. So what are the other ways to evaluate for hiatal hernia? I put an asterisk right from the bat because all these studies used intraoperative assessment as the gold standard to determine whether there's a hiatal hernia. But we saw from the results before, that's not accurate. So that makes it, unfortunately, a little difficult to interpret the results of these studies. Esophagram can reliably detect large hernias, but its Achilles heel is detecting small hernias. That's for a couple reasons. One is that when the patient swallows, a normal patient, the LES will elevate above the diaphragm. That could look like a hernia. Also, the diaphragm is not so easy to see often, especially in obese patients on an esophagram. And then there can be difficulty interpreting the A ring, which is at the start of the esophageal vestibule, still on the esophagus, and the B ring, which is the Z line, the G junction, and the hiatus. Sometimes those three, it's not entirely clear which is which. Because of that, generally esophagram in studies have had low sensitivity, meaning that it doesn't detect small hiatal hernias, but a high specificity. So really no better than intraoperative assessment. How about endoscopy? Well, on endoscopy, you look for a hiatal hernia retroflexion and then grade the valve based on the Hill grade. And so I think because of this, there's a correlation both anatomically and physiologically on how you're looking for the hernia and the method by which the hernia causes reflux, basically degrading the flap valve at the G junction. And backing this up, there's been good correlation in studies between Hill grade and pH studies. So kind of in my mind, this is the best, most accurate way to assess for small hiatal hernias. And when you compare it to intraoperative, there's a little better agreement, but still not great agreement with intraoperative findings. So just to summarize all this, I'm going to grade each modality, and I thought I'd give it like a 5-star Yelp rating for both assessment of reflux and hiatal hernia. So history is a fairly good assessment for reflux, but obviously, aside from whether the patient has reflux, it doesn't give you any information as to whether the patient has a small hiatal hernia. Esophagram gives you no data about reflux and is a very poor assessment, especially for small hiatal hernias. So I think because of this, routine esophagram really does not have a role in the preoperative evaluation of patients undergoing bariatric surgery. Endoscopy is a fair to poor detector of reflux, especially if a patient's on PPI. But I think it's really the best assessment for hiatal hernia. Not perfect, but I think good. And another major advantage is allows for detection of Barrett's and eosinophilic esophagitis, as well as other gastric pathology. pH monitoring obviously is the gold standard for reflux, but doesn't give you any information about hiatal hernia unless you're doing a catheter-based study and manometry, and then potentially could tell you a little bit about hiatal hernia. And then intraoperative assessment obviously doesn't tell you about reflux, and I think hiatal hernia is unclear. It's not a good assessment, and I think this needs to be studied more because we don't really know much about the interrelator reliability between surgeons, how surgeons even assess for hiatal hernia. So I think that's something that needs to be researched a lot more. So based on this, I'm going to give you some potential algorithms, and I'll be a little slippery and give you 3 potential algorithms that I feel like are all reasonable and supported by the literature. The first, I would call this the old school doc. This is just assessing for reflux based on the patient's history and symptoms, and then doing an intraoperative assessment for a hiatal hernia. You should do an EGD if the patient has warning symptoms, dysphagia, weight loss, melena, anemia, and pH monitoring if you're considering a sleeve and there's not clear reflux symptoms or atypical symptoms. The scoper, this is what we do at our institution, is using history for reflux and then doing an EGD on everyone to look for hiatal hernia, Barrett's, and other pathology. And we found a lot of Barrett's in our patients, probably about 3% of patients. And then doing selective pH monitoring, again, if someone's considering a sleeve and they have borderline symptoms. And then I would say the last is the Cadillac. This is doing an EGD on everyone and doing a pH monitoring on everyone considering a sleeve. And I think that's not unreasonable given the amount of patients who have reflux and the amount of patients who have silent reflux. Thanks very much.